My name is Lars Hagander, and I will talk about the evidence and solutions for achieving health, welfare and economic development through surgery. So I'm one of the co-chairs of the Lancet Commission on Global Surgery, and that will be the gist of my talk. I googled rocket science, and that came up with this advanced formula over there. So we'll see if it's going to be rocket science or not. I might be more simple than that. So I'm across the bridge in Lund University. That's where I'm based. I'm a director leading of the WHO Collaborating Center there for Surgery in Public Health. And we have a team with PhD students and examiners. And we are running a 5-week course in global surgery at the university, and I will try to compress that 5-week course into the next 15 minutes and see how that goes. So this is the university library in Lund, and I will start just by explaining a little bit where I'm coming from. I work just on the other side of that building in the paediatric surgery department. I'm a consultant there, and this is sort of the hospital environment that you may be familiar with: robotic surgery and high tech and neonatology and all that. And 10 years ago, when I finished my training, I was on the plane to Bangladesh, and frankly to get exposure, to help, but also for egoistic reasons to get volume and become a better surgeon myself. What struck me though was that the surgery that I encountered was very essential, basic surgery, if you may, burns and trauma, a lot of burns and trauma, mismanaged, like patients that hadn't received proper care initially who came to the public hospital where we were working. We saw laparotomies, emergency laparotomies from ascariasis or appendicitis, but still that was big volume, and then of course cesarean sections. So that was the surgery in public health that I was struck by in this setting. I was also struck by the limitations comparing to my Swedish context, and again, how the low-cost solution dominated everything. The reusing of gloves, the equipment and the simplicity, and the hygiene that you have to compromise, and so many things that we are unused to compromise with. So the children came late, they were malnourished, they had other diseases, the equipment, particularly anesthesia, was very, very limited. So that for the most fragile ones, we didn't even use general anesthesia, we just tied them up, because putting them under general anesthesia would be too risky. So better surviving in pain than dying from general anesthesia. So that was the situation. And for me, coming home, talking to my public health colleagues, it struck me that there are certain myths about surgery and public health. One, well, the bigger picture, surgery, clearly it's not, given everything that's going on, it's not a public health concern. Second, it's too expensive for these contexts. Clearly it's too expensive, we know. And also it's not safe, and I guess the anesthetist from Bangladesh would agree that, under many circumstances it's unsafe. So these were the myths, and I was inspired by this gentleman, who you all know, I guess, the Director General of WHO, Halfdan Mahler, who said that the vast majority of the world's population has no access whatsoever to skilled surgical care, and little is being done to find a solution. This was in 1980. And he was pushing for this area already then. But from then, the surgery was not included in the public health agenda, so to say, the health for all, the Millennium Development Goals, and perhaps not so much in the Sustainable Development Goals either. And as a Swede, I turned to this person, I don't know if you know, Hans Rosling, who is the epidemiologist, one of the most influential Swedes ever, who was creating his Gapminder database. You can search and you can create your X and Y axis. Here it's child mortality on the Y axis, and every blob is a country, and then how rich the country is on the X axis. And this is the world in 1962. 1 in 5 children dies, and a lot of countries are very, very poor. And then 1990, the beginning of counting for Millennium Development Goals, child mortality goes down, countries become richer, and then in 2012, for example, even lower child mortality, even richer countries. So in the world that we live in now, the children survive their infectious diseases of childhood, infancy, and they are struck by other sorts of diseases, of course. And the health systems where they live are wealthy enough to deal with this dual burden of disease. So this is the message of Hans Rosling, I guess. But if he wanted to do a similar graph showing surgery of some kind in his database in 2012, that wouldn't have been impossible because there would have been no data. So in the World Health Statistics document from the World Health Organization in 2013, this wealth of information on global public health, there was almost nothing on surgery. So then it's very difficult to disprove those myths that it's not a global health concern, that it's too expensive, that it's not safe, because there's no data being collected. And that was the rationale for this initiative, which was called the Lancet Commission on Global Surgery, which was co-chaired by King's and Harvard and Lund, but it was like a team effort with contributors from more than 100 countries, with commissioners, advisors, adjunct researchers, and collaborators, primarily in ministries of health and NGOs. So a very strong push between 2013, 14, and then publishing in 2015. And he was trying to understand not so much the crisis side of things, which has been the typical idea. If you say global health and surgery, people think of Doctors Without Borders, a surgeon coming down and fixing it. But if you think about development, very few people would think about surgery. So there was a lot of data collection. There were meetings with experts in the field, for example, the professors of Harare and Johannesburg talking in a meeting in Sierra Leone. And there were a lot of advocacy work. For example, this is the World Bank director, the president of the World Bank, saying like, surgery is a neglected area, let's do this together, I urge you to challenge this injustice. So quotes from the very top, making sure that doors are open for this kind of message. And then in 2015, we published the results, and there were 5 key messages, and I will go briefly through them. 5 key messages. The first one is that 5 billion people don't have access to safe surgery in time when they need it. So 5 billion people, that's more than half of the world's population. And how do we come up with this modeled number? We consider 3 surgical conditions. It's C-sections, emergency laparotomy, and open fracture, if you have access to those as a patient. And then we take one patient who has to live in a place where he can reach a hospital within 2 hours. So in a timely fashion, 2 hours, we take that as a cutoff because that's the tradition in obstetrics. And in that hospital, you need to find someone who can deliver that surgery to you. It has to be safe, so that needs to be a pulse oximeter there in that hospital, for example. And you, as a patient, should be able to pay for the services. And if you add all those ifs, you come up with that number of 5 billion people, because most people get stopped on one of those occasions. So, for example, in obstetrics, you can see that lower middle, high-income countries, what is the access to emergency obstetric care? So in low-income countries, if you're a woman and you need emergency obstetric care, you're more likely not to be accessing that service. And the reasons are plentiful, of course. It could be let's see. I mean, it could be equipment, clearly. It could be staff. So together with the WHO, we, for example, this commission work, for the first time found out how many surgeons and obstetricians and anesthetists there are in each country of the world. That mapping had to be done for other categories of healthcare personnel, but not for these surgical specialists. Thinking about access in that way, you have to also consider that many patients don't even know that that kind of help is available. So just being able to seek care is the first step. The second key message, so the first one was about the vast majority having not access. The second one was that we need about 50% more procedures in the world to meet the gap. So 150 million more procedures every year to meet the most basic population needs. The key message 2, we need another 143 million more procedures annually to meet the most basic demands. And if you could see this graph from Dr. Weiser, Tom Weiser, we're comparing the number of childbirths, for example, to the number of major surgery in the world. You see that today, even though we're lacking 50%, it's clearly a public health concern with this large volume of surgery being done. But if you take the world's poorest third, they only get 6% of that volume of surgery. The third key message was the fact that it's very costly for patients. People don't plan to get a femur fractured today. So 25% of every patient in the world who will have surgery will get ruined by paying for that service. So you have the disability, the mortality, but also the poverty that comes with paying for the surgical services. But if you look on a national level, and this is the fourth key message, if you would be a minister of health, or minister of finance, if you would invest in surgery, that would be a very, very good deal. So investing in surgery is very, very cost effective. You get a lot of benefit for a very low cost. If you invest in essential surgery, of course, not the most expensive ones. This graph shows that if you, until 2030, as a country, don't invest in surgery, and you let these young people have untreated trauma or obstructed labor, how much would you actually lose from your GDP by not investing enough in surgery? And when a Minister of Finance sees that you actually lose a couple of % of your GDP growth, that's, you don't have humanitarian arguments, you have financial hardcore arguments to make the case for including surgery in your health system. So that has been influential. The fifth key message was the fact that surgery is sort of embedded in many other different diseases. If you look upon this graph from the Global Burden of Disease study, showing the combined metrics of DALI, premature death and disability, all the minuses from unhealth in the world. Blue is non-communicable diseases, red is infectious diseases, and green is trauma. That's like the whole unhealth of the world. You don't see surgery as one of the boxes because it's not a disease. It's sort of integrated in all different diseases. So if you want to be successful in your pediatric program, you need surgery. If you want to be successful in your infectious disease program, at some point you will need surgery. You will need it for cancer. So you cannot forget. We sort of made the case that surgery is included in all that. We can see in surgery, for example, in Sweden, the red bars includes how many of cancer admissions that at some point during their admission have surgery as part of their care, and that's age on the x-axis. The same you can show for infectious diseases. By admitted patients, it's actually quite common in South Africa and Sweden to have a surgical procedure as part of your care. So we tried to make the case that surgery is sort of the elephant in the room. You need to consider surgery moving forward. We cannot be neglected no more. And by doing this rocket science, is sort of defining that elephant in the room and sort of trying to get that message out. We were successful to get media attention there in 2015. Like these key messages, consider us. And we got a lot of support from the different surgical societies of the world. They said, we're behind this, we think this is important. But most importantly, the World Health Assembly in 2015 passed a unanimous resolution that surgery is required to achieve universal health coverage. And that Walt will speak more about that. And of course, this was not just Lancet Commission, it was a big push, academic push. For example, the left document here was from the World Bank, making the financial argument even clearer. So there were from many directions leading forward to that World Health Assembly resolution. After the resolution, or in the resolution, you may think, how do we move on from there? And in the Lancet Commission, we defined 6 indicators that Hans Rosling could use in his y-axis to present, that we thought that every country should collect in order to have a sense for surgery in public health. From beginning from 2013, these were actually included in the top 100 list of indicators that the WHO promotes, and also from the World Bank's list of health indicators. That has been taken off, so now surgical workforce, for example, is one of the indicators for universal health coverage. So not only moving forward, I think many countries will have to collect this information. Different countries have made efforts to collect these data. Brazil here, for example. And then you have to consider, in my country, how many procedures would we like to provide to our population? How many % of the population should get that? Should it only be in the city, or should it be far out in the countryside? And how much should be prepaid? How much should be paid up front by out-of-pocket expenditures? If you fill that whole box, you have universal health coverage. So every country has to decide that, and that's called the national surgical planning process. And that is something that the World Health Organization is pushing very strongly, and that Walt will talk more about, together primarily from the Harvard group. I would like to end with this quote. When people look back at our time, they will be amazed at one thing more than any other. It is this, that we do know more about ourselves now than other people did in the past, but that very little of this knowledge has been put into effect. Doris Lessing, in prisons we choose to live inside, and I think being here, I'm honored to be here from the Masanga group and the Copper Care group. You have really put this into effect, so very, very good. Just on that note again, I think it's not rocket science, it's more complicated than that, so thank you very much.